Good afternoon, everyone, and I'd like to welcome you again to the February Friday Speaker Series here at Jefferson College. For those that have not had a chance to meet this afternoon, my name is Roger Barentine. I'm the Director of Marketing and Public Relations here at the college. And normally, of course, you would be greeted by College President Dr. Ray Comiskey. Unfortunately, he is not here today, obviously. He is traveling on behalf of the college today in Washington, D.C. to take part in a national legislative summit. He'll be joined, in fact, later in the course of the weekend with President-elect Dr. Dina McCaffrey. And they'll be visiting with our legislators about some of the very important topics that are not only important to Jefferson College, but to all of higher education in the state of Missouri. So he asked me to tell you that he regrets not being able to be here today, but certainly appreciates the fact that you all have shown up and participated in the Friday Speaker Series. I do have one individual that I'd like to acknowledge before we address our program this afternoon, and that is John Winkleman. He's our guest, who's a Community Relation Manager for Mercy Hospital Jefferson. John was instrumental in really arranging and bringing this program today, so I want to thank him. Many of you know John, not only through his work at the hospital, but as well, he's a former Jefferson College Board of Trustee member. You'll see often his articles in the Leader, and you'll also hear him quite frequently, twice a week, in fact, on KJFF and Festa. So, John, we appreciate all the work that you do. Thank you. Well, our program today, titled Falls Prevention, is being presented by staff members with Mercy Hospital Jefferson Rehabilitation Services. You see them here awaiting to my right. They include Eric Baldonado, who's a director, Lori Tatalovich, Jen Gaia, and Jen Gilman. I hope I didn't butcher those names, so I'm sorry if I did. You're going to hear a little bit more about each of them here in just a moment. The Mercy Jefferson Rehabilitation Services Department actually includes an inpatient acute rehabilitation unit as well as an outpatient clinic. And as well, the outpatient clinic offers specialized cardiac rehabilitation services for the community. The dedicated team includes the medical director, physical therapists, occupational therapists, speech pathologists, social workers, and nurses. And then other individuals associated with that team include dietitians, pharmacists, and psychologists. So our team today will be sharing information and provide practical ways to reduce the risk of falls for all populations. And of course, we can never be too young for that, right? Right, absolutely. They'll be discussing household modifications, balance, exercise, and medical factors to be cognizant of. They'll also remind us of safety features that we may often brush aside given the busy lives that we do lead. So please join me in welcoming Eric, Lori, and the two Jens from Mercy Hospital Jefferson.
Well, thank you. I am Eric Baldonado. Each of us will introduce ourselves when we get up here. You did a great job, better than I probably would have wrote anyway, so thank you, Roger, for that. Thank you for Jefferson College for having us out. I'm Eric Baldonado. I'm the Director of Rehab Services and the Director of our Acute Rehab Unit at Mercy Jefferson. I am the only outsider, so I am not a St. Louisan. I was actually born in Nebraska, raised in Kansas. One Nebraskan, good job. All right, so raised in Kansas, and then I moved to Festus almost 5 years ago now. So, but I've been with Mercy for 18 years, and with Mercy Jefferson for 5 years. Physical therapist by background, so that's what I did practice. Unfortunately, I try every once in a while to see patients, but I don't get to do that very often, if rarely anymore. I get to attend meetings. Which is not really why I went to school, but that's neither here nor there. Anyway, we wanted to come and talk to you about falls. Falls is very important to us all as a profession, and I'm gonna kind of give a broad overview of why I think it's important to you. I hope it's important to you. I think you'll find through this presentation that if it's not important to you, if you open your minds to this presentation, it will be important to you in the next 30 minutes because we're all at a falls risk. And some of us at a much higher falls risk, and it has significant impact on people's lives when falls happen. So I'm going to give you a few statistics and kind of open this up. So why is fall prevention our topic? We're going to talk to you about why it's important. So we started off with, I don't remember who started. You started, Roger, talking about money. Well, money is one of the big reasons that falls are important. We're going to talk about why or if you are a falls risk, and then what we can do to help prevent falls. So why is it important? So each year, 3 million older people, so that's 65 or older, are treated in the emergency room for falls injuries. So that's quite a few. Here's our money thing. So 29 billion is paid by Medicare, 12 billion is paid by private payers, and 9 billion is paid by Medicaid. So can I add real quick? 21, that's 50 million? Is that what that is? $50 billion in just providing care for people that have a broken hip. Well, falls, most of those are going to be broken hip dollars. 1 in 5 falls comes from or results in a serious injury, which is head injuries, and then of course fractures, hip fractures being the biggest cause there. Okay, so then when we look at what happens when we fall, that's when it becomes even more important. So first we want to prevent falling, but if we do fall, then the statistics start to get very unfavorable for us. So 1% of those that do fall are going to die within that first year. 24% are going to have to be hospitalized. 76%, the good news is, are going to be treated and be able to release. The question mark under millions is how many people, even in this room, have fallen and maybe just had to sit down for a little while, or sit down and lay in bed for a couple days, or go to the doctor and get some medicine, or things like that. So there's some falls that just cause minor injuries, but they can cause major injuries after that by causing some of these other things which cause to further falls. So the biggest thing is we want to prevent the falls to begin with. Okay, so we're going to continue to spread my cheery news. I'm the happy guy. These guys are going to talk to you about how to stop it. I'm going to give you all the bad stuff. There's good news in here somewhere. So 25% of those who have fallen, and I saw this right before I sent this over, but that should say and fractured a hip. So 25% of those that have fallen and fractured their hip pass away within a year from their fractured hip. Okay? So that's a staggering number. So I'm going to guess most everybody has either experienced a fractured hip, knows somebody, a relative or a friend or somebody from church who's fractured a hip, and so it's not something that is uncommon. Actually, my mom fractured her hip in June, and so I've kind of gone through this. So it can be very personal to a lot of us. And then more than 40% of those that are hospitalized from hip fractures will never return home again. They'll go into long-term care. There's multiple reasons for that, but it's very traumatic to fracture your hip. It's very traumatic to go through surgery after a hip, but then also your comorbidity. So those things that you already have as illnesses prior to the fracture in your hip tend to rear their ugly heads even more once you do fracture your hip and are going through all of that. All those things together lead to these statistics, which, again, isn't the happy news I'm here to spread. Okay, so now this is where we're going to get into the real life and where you have to open your mind a little bit. All you need to do is answer yes or no to yourself, and that's it, okay? So here's all of our questions. All of these, this is kind of small. I hope everybody can read it. I hope way back there we can read it. But for each of these things that I put up here, if you answer yes to any of these, any one of these, you're at an increased risk for fall. The more yeses you give, the higher increased risk for fall you are, okay? All right, so here we go. Whoa, that's a big list and it's small. Can you even read that way back there? Yeah, because that list, okay. So if you've fallen within the past year, okay, you're at an increased risk for more falls. If you have been told, doesn't mean you do, have you been told to use a cane or a walker, you're at an increased risk for falls. If you feel unsteady at all when you're walking, if you have to steady yourself on furniture, or furniture surf is what we call it in the profession, our fancy term, furniture surf, when you're walking at home, you're at an increased falls. If you have to push up from a chair to stand up, you're at an increased risk for falls. If you have some difficulty stepping onto and off of a curb, you're at increased risk for falls. If you frequently have to rush to the bathroom, you're at an increased risk for falls. Actually, the most likely place for somebody to fall at home is in the bathroom or in the journey to the bathroom. If you have any lost feeling in your feet, you're at an increased risk for fall. If you take medicine for pain or any heart medicine, you're at an increased risk for falls. If you take any medicine to help you sleep or improve your mood, you're at an increased risk for falls. Okay, is anybody still gone completely no on this list? What about our young kids over here? No, not even no's over there. There's no, okay. That's kind of what I was going at here. All right, if you're sad or depressed, if you weren't 17 minutes ago, you are now. Okay, all right. Or the biggest thing, and the thing that most people don't realize, is the highest predictor of falls is if you have a fear of falling, you're almost 50% more likely to fall than those that don't have a fear. Okay, so now that we know everybody in the room, including those of us with less experience, are at a risk for falls, this lovely group of young ladies is going to give you the good information on how we can prevent those falls or what to do.
So I'm the first Jen that you'll hear from today, since there will be two of us. Just a little bit about me. I'm an occupational therapist and the lead for our acute rehab unit, which was that unit that our lovely person who introduced us was talking about. And so occupational therapy, this is the part where I get to do my spiel because we're the lesser known of the therapies. Our main focus is, in that particular setting, is activities of daily living. So if after you've had a fall and you fractured your hip, we'll teach you how to do all your dressing and your bathing and all those things that you were doing at home before, up to those more complex tasks where if you love to garden, we'll help you get back to those things. So that's we kind of call ourselves more of the hippies of healthcare because we want to do what you want to do. So I'm going to talk a little bit about home safety and some potential ways that you can increase the safety of your home so that you'll have a decrease in falls in that setting too, since that's probably where most of us are most of the time and we feel most comfortable there, and so you kind of let your guard down, and so the chances of falling in that more comfortable setting are a little bit increased. So over half of falls that occur each year happen inside of your home, like I said, because you feel very safe inside of your home. You think you know where everything is. Maybe like Eric was saying, where you use the furniture or furniture surf around your house because you know exactly that when that wall ends, you can grab onto the back of the recliner, and then you'll make your way over to the counter, and then you use your cat's scratch stand until you get a little bit further. So you have everything all mapped out in your house, but maybe one time a visitor comes over and moves that chair that you always surf on, and so then you have to do some unstable walking from place to place. And so that's one of the things that could be a preventable fall. So the first step to decreasing that fall risk is identifying the changes. So I'm going to talk a little bit about structural barriers versus cosmetic barriers, and I have these listed on the handout that you all have received, the difference between them, but we'll also go over them today. I like this handout because it does have a pretty long list of ways that you can make these changes, but we'll also go over some of those too. Okay, so for structural barriers, the definition of that is the foundational framework of your home. So the actual structure of your home. These things are a lot more difficult to change. So your door frames, a lot of older homes have narrower door frames that if something did happen, like you fell and broke your hip and you were returning to home at a wheelchair level, a lot of older homes, a wheelchair might not fit through the bathroom door in order to like do your shower and get to the toilet. So those would be the structural barrier. The number of stories in your home. If you live in a split level home and you have to go up or down stairs no matter what, as soon as you get inside, then that's a structural barrier. The stairs in general, and then like permanent ramps. Those are structural parts of the home as well. And then we get to more cosmetic items. So this is non-permanent fixtures of the home. So like your lighting, if you have all overhead lighting or if you have mostly lamps, overhead lighting is going to give you a lot more clarity through the room. And also, I know it seems that some of the light bulbs that may have been brighter at one point seem a lot dimmer now, and that honestly is something that I've had patients mention to me, that they used to buy what was soft white light bulbs, and now whenever they buy soft white light bulbs, they can't see anything in the room because it seems like the bulb is dimmer. And whether that's true or not, my parents have actually mentioned that also. Whether that's true or not, like changing the lighting in the room can also, that's a quick cosmetic barrier that can be changed. The flooring, the type of flooring that you're having, if you have carpet or if you have hardwood, if it's kind of a hybrid, like laminate type flooring, so those are other just cosmetic things. Appliance placement. We do home evaluations on the acute rehab unit, so sometimes we've come to homes and there's been an option of having this appliance in a slightly different place, and all the hookups still work, and it would give that person a lot more space to be able to navigate through their kitchen a lot safer. And then things like cabinetry. So for identifying these barriers, identifying potential structural barriers by surveying all of the entries and exit of your home, like looking at the stairs for the entry from the entryway, and things like that. But with these, the most important thing is that you're going to want to consult a professional before altering any structural barriers. So a lot of times if we know someone who's handy, then you might think, oh, Neil can just come over and blow out those stairs and give me a ramp. You want to make sure that Neil really knows what he's doing, because it's going to be more unsafe if you have someone who's not a professional make these major changes to your home, and then something happens. So make sure that you're consulting a professional. And then identifying cosmetic barriers by surveying the spaces inside the house for potential fall risk or fires or poisoning, things like that. Those cosmetic barriers are always going to be easier to alter than the structural barriers. It would be very easy for that same Neil to maybe move the rug rather than remove your stairs. Okay, so some cosmetic safety tips. Removing clutter. This is the biggest one. This one is also, it's the biggest one, but it also seems to be very difficult for people who have been living in their home for a very long time, because it's very easy to accumulate things and feel a very special attachment to those things. And so removing the clutter can be very difficult. And also arranging furniture to allow walking space. This kind of relates to the clutter. If you are a collector of antique dolls, then you might feel that that it might seem like those things are involved in both of these things. So maybe arranging the stands that you have them on, and also also removing them from like the floor space area so that you have enough space to get through and walk. Removing throw rugs. This is one, whenever we're on home evaluations, that's usually the first thing that we end up doing, because honestly, usually whenever we're bringing the patient into their house, one of us trip over the throw rug, or they trip over the throw rug. Somebody trips over the throw rug. And so, so that's another big one. Non-skid mats in the restroom and showers. This is a really quick cosmetic fix. If you are using a shower chair, which is also on the list, if you're using a shower chair, getting up and down from that shower chair, it's going to be a lot easier and a lot safer if you have a non-slip mat in the bottom of your tub or in the bottom of your shower, and also a grab bar. So all of those things kind of go together as well. So that's my spiel on home safety. So I will throw it over to Lori to talk about the next thing.
Thank you, Jen. So I'm Lori Tatalovich. I am a speech-language pathologist by background, currently the manager of rehab services in the acute rehab unit at Mercy Hospital, Jefferson. I've been born and raised in Jefferson County. I've been at Mercy Jefferson for a little over 11 years now, so I'm very familiar with this community and trying to help meet the needs of everybody. What I wanted to talk a little bit more now about is cognitive impairment or cognitive changes. So cognitive changes or decline can play a large factor in increasing your risk or frequency of falling. So whenever I talk about cognition or cognitive changes, what this really looks at is decreased in memory, decreased in reasoning or problem solving, decreased safety awareness, and decreased comprehension or understanding. So what that basically means is, do you know when to do the right thing? If you see something that's dangerous, if you see those throw rugs, if you see that bathtub is slippery when you're trying to step in and out of it, what are your next steps? We see a lot of patients in our rehab unit. Maybe they're in for their hip fracture, maybe they've noticed some confusion or just changes in their thinking since they've been in the hospital. And that's what we really work together as a team to be able to identify that and be able to make those safe choices whenever they're returning home. So decreased memory can absolutely affect them if they're not remembering when to use their walker, if they're not remembering to reach back before you sit down. And then safety awareness, just being able to identify what is safe, what is not safe, and if it's not safe, most importantly, what are your next steps? So the first kind of line of defense, if you start noticing any changes, is look at some of those quick things that can be treated, addressed by your doctor. So we look at any causes that may create these cognitive changes. It starts with metabolic, checking your eyes and ears, looking at your nutritional needs, mental health, is there any anxiety or depression? Is there a tumor, toxicity, or trauma that could potentially be affecting it? Or any history of alcohol or drug use. Of course, you want to follow up with your healthcare provider for any signs or symptoms, but these are things that absolutely they can start addressing, doing imaging, testing to see what is the root cause of that, and most importantly, then being able to fix it. So cognitive impairments, we identified that something's going on. Maybe you're just not thinking as clearly as you did before. You're not remembering things the way that you did before. So what do we really start doing about it? Maybe it's either yourself or your loved one or a friend from church, but you want them to be successful in the home. We want to keep people at home as long as possible. So there's some certain things that you can do to try to help keep them successful. Provide that attention and support in the home to increase success. So we help provide medical alerts such as Lifeline, different alarms, being able to alert if somebody's getting up and maybe they shouldn't. They wear that little thing around their neck or their bracelet to be able to alert them if the fall happened. Any automatic or stove shutoffs or devices, especially if somebody's having a difficulty remembering things, are very forgetful. They may turn the oven on, walk out of the room. They make alarms now to help identify if that's been on for too long. Any signage throughout the house, and our speech term for that is external memory aids. So any signs or things that you can post around the house to help remember, oh, don't forget to get up without your walker. Don't forget to call for help before you get in the shower because your daughter's always going to be there when you take a shower. Just different signs. The front of the refrigerator is the perfect spot to put those because everybody's going in and out of the fridge multiple times. You're going to see that sign multiple times a day, just to try to help cue that memory. And then home modifications that Jen was talking about absolutely helps keep them safe. And then any family training or education. On our acute rehab unit and even in outpatient, we focus a lot on family training, family education. The more resources people can have and support in the home, the more safe and successful they can be. And we really want to tap into all those resources and help provide that education to anybody who's involved in that care. Then, of course, just referrals is needed to help increase that functional independence and safety. So you're hearing really from all three disciplines today between physical, occupational, and speech therapy, but we're absolutely a part of that journey. And our number one goal is to keep people home and safe, and really each discipline plays a part, especially in fall prevention, and addressing that truly as a team to help keep people safe. So this is kind of that slide. Eric talked a lot at the beginning about just the fear of falling and how impactful that is and how much that increases your risk of falling. So this is kind of the perfect slide to really summarize that, because if you have the fear of falling, you're just going to kind of get in this cycle. So you're scared of falling. Either you've had somebody close to you that's fallen and has gotten hurt, or maybe you fall once before, and that fear is just starting to build. So you're starting to get some anxiety about it. You might start feeling more depressed about it, just these changes, and maybe you're not being as active as you were before. So you stop being active because now you're scared. You're nervous that you're going to fall again. You're nervous that you're going to get hurt. You're nervous that you're not going to be able to stay at your home. Your mind just starts wandering and all these things that could happen. So you're getting anxious, you're getting depressed, so you just stop. You think, if I'm not as active, then I can't fall. If I'm not doing as much, then I'm going to be okay. And since you're not active anymore, that leads to weakness. So now your body's getting weaker because you're not as active as you were. And then now that you're feeling weaker, again, all those other symptoms kind of coming around, now you're starting to feel a little more socially isolated. Maybe you're not getting out as much as you did before. Maybe they don't see you as church as they used to before, and you're just feeling more withdrawn. And it just starts this cycle kind of over and over that really plays a part in it. And so that's really kind of the big thing that we want to hit home with, is that we want you to be safe. We want to continue to prevent falls from happening and make sure that you guys are all active and safe, but also addressing this real fear that's out there, and getting referrals to those appropriate resources, whether it's talking to your doctor, seeing physical therapy, occupational therapy, speech therapy. There's resources out there to help you stay active and social while still being safe at the same time. So then I'm going to lead into Jen number 2 to go over that a little bit more.
So my name's Jennifer Gillum. I've been with Mercy Jefferson for almost 12 years, much like Lori, and I'm the supervisor for outpatient therapy services for Mercy Jefferson. And we do have 3 outpatient clinics. We have the one at the hospital, we have one in DeSoto, and then also one in Imperial. So we're going to talk a little bit about physical impairments or biological reasons why you may have or may be more at risk for a fall. And so the things that may be impacted, like Lori was talking about, you start to stop moving and you start to lose strength. So that's one thing. When you do that, then you also may be more fearful, like Lori talked about, of getting up and moving, and that also can impact your balance. We may have issues with sensation, whether that's from a neurological issue or maybe from like diabetes, if you have something like neuropathy. And then you may also have issues with flexibility and from sitting or being stationary too much. And then posture is also another thing. A lot of people that I see, they come in, maybe they're with a walker and they're bent over, and then their center of gravity is already forward, and that also can put you at more of a risk. So what we would do as physical therapists or occupational therapists or speech therapists is we would look at all of the systems together and figure out, what are your issues, where are your impairments, and so we would do what we call a multifactorial assessment. And so we will look at your gait mechanics, or if there's an issue with vision. Also, we'll do specialized testing. Some of that may include a test called a timed get up and go, or a 30-second chair stand, or a 4-stage balance test. And a higher level balance test that we may do is something called the Berg. All of these have norms, so we know, like, if you score a particular amount on, say, the Berg balance test, it'll put you in a category of if you are at a low risk for falling, or maybe a moderate or even a high risk for falling. So these are specialized tests that we can do in therapy, which can give us a better idea of where we would need to focus our attention to be able to help you improve and be at less of risk for falling. And then again, we'll look at your posture. Like I said, if you're bent over, you're already forward. And then what if you trip on that rug that you haven't moved that Jen was talking about, and then you're gonna end up on the floor, which none of us want to have happen. We also may look at footwear, which is something that a lot of people come in and they have either shoes that are too loose, or they're not tying their shoes because they don't have the flexibility to bend over to get them tied correctly, and that can be a problem. And then we'll also look at, do you need assistance with transfers, which is basically, do you need assistance to get up from a chair? So Jen was talking about getting up from that bath bench. And so do you need assistance with that? You need someone else to help you. People who need help with their transfers and their mobility sometimes don't get that help, or don't wait for that help, and then they end up falling. So things that you may see, you might be thinking, well, I don't know if I'm at risk for a fall, even though Eric went through that entire list, and I don't know that there was anybody that said no, they don't have any of those issues. But just in case you're still wondering, or so maybe you're thinking, maybe I know somebody else who's at a risk for falling, and maybe they need some help. Things that you may see is maybe they lean to one side, or like I talked about with the walker, they're leaning forward, or maybe they're even leaning back because they're thinking they're trying to compensate. And so that could be definitely a problem. They may also have a slower gait, or I'll see like shuffling, because they want to make sure that they don't take big steps, because they're fearful if they take too big of a step, then they're going to end up on the floor. You may see somebody, like I talked about, getting with difficulty getting up out of bed or up and down from a chair. So they may be like having to like really rock to like get the momentum going to get up out of the chair. Or I see people walk in with a wider base of support because they're thinking that makes them safer. And then people who have difficulty negotiating steps. So if you have a family member or friend, or even yourself, who you have difficulty going up and down the steps like they talked about, maybe you need a ramp. So just looking at these things and trying to see if there's maybe a chance that they could come to therapy, or anyway, you could give them some of the tips that you've learned here today. So what's next? So once a therapist does their evaluation and they figure out if your problems are with your strength or your balance or your flexibility, then we can make recommendations for particular exercises that'll help to address those issues. We may also recommend, if you come in without a walker or an assistive device, a walker, a cane, or anything like that, maybe that's something that you need in order to be able to be safe and still be able to move around, so you don't continue in that vicious cycle that Lori was talking about of, well, I don't feel safe walking, so I'm just going to stay sitting or planted in my chair, which isn't good either. And then we can address those mechanical deficits. So if we notice that shuffling of gait, and we can encourage you to take a bigger step and reminding you that we hit with our heel and then shift our weight onto our toes, those kinds of things. And then again, those recommendations if there's an issue with footwear. But ultimately, our goal is to make sure that we encourage you to be as mobile as possible, but to be as safe as possible doing that. And then encouraging you to not have that fear of falling, so you could get out of that vicious cycle. I think that leads us up to if you guys have any questions for any one of us.
You were talking about the bird test.
Yes.
What is that exactly?
That's if you got bees.
It's Berg,
I
B-E-R.
thought you said bird.
That would be much probably.
Yeah, that would.
We're gonna see if you can fly. It's B-E-R-G, and basically it's a 14 question or 14 step activity session or activity that tells you, like we have you stand with your eyes open but your feet together, and how long can you stand in that position, unassisted and without falling. And then we may have you stand with your chosen base of support, but then turning your head from side to side, and then turning in circles and getting up and down from a chair. So there's lots of different activities within that. That's why it's a very
Or
specialized.
stand like a bird on one leg.
Yes, single leg standing is one of the parts of the test.
You don't have to flap though. You don't have to flap, right?
Right.
That's what you do with
Yes,
the therapy.
you come to us so we
Do not do that at
can,
home.
so we can make sure you're safe doing it, and then,
Do we have to fall first?
no. We'd prefer you don't fall.
Right.
I mean, we've spent a lot of time talking about falls, but that's not, definitely our goal is to make sure that you're safe and that you don't fall.
So I would say along those lines, I think one of the biggest things that we have is we concede with our physicians that I'm just getting older, and so that's just part of getting older. I would challenge you, and I would have you challenge your physician that that's truly the answer. So frequently some things happen just because we get older, but not everything can be explained away just because we get older. Because if you can look around and see even people within this room that are more active than you or more active in the community, those are the same age but maybe more mobile than you. So if you and the physician have decided, well, it's just because I'm getting older, I would challenge that thought, because that's not necessarily the case, because then that's how we end up with those falls, is waiting for me just to get older, and I'm gonna fall sometime, I've just gotta wait till it happens.
You was talking about going up and down steps. I had my son put what the arch really handles for cabinet, put on the side of my post going up my steps, and that really helps me.
Okay.
I only got 2 steps, but still you're coming in with a big old purse and your groceries, you need extra help.
Yeah, and that's, we can too work on being able to be mobile and carrying something in your hand. Like, that's something definitely that's functional and an everyday or most everyday kind of experience that, or activity that you go through, that it'd be helpful to make sure that you can do that safely.
Yes, sir.
Do you have any suggestions on how to get up if you should fall?
Call 911.
You want like a step-by-step directions?
With a presentation.
So let's start with first, we have to make sure we're okay. So the first thing you need to do is make sure that your head's not bleeding or injured, and that you can move your hips. Because if your head's bleeding or injured, or you can't move your hips, you're gonna need 911. So if all of that's okay, then you typically get onto your hands and knees and work up from there. But I would start with finding somebody to help you or calling 911. But if you're definitely bleeding from the head or can't move your legs, go in and try to get up. And don't wait there for 8 hours and then crawl over to a phone. We have plenty of horror stories we hear at the hospital about how I was a great warrior and crawled across my house and got to my phone and think that's not good. Does that answer your question?
I have trouble getting up, and so I'm going to go back to my easy yoga class. But one of the things they taught me to do was to roll over and put my strongest arm and try to push myself up. But most of the time, I need a hand or a chair.
And so yoga is actually one of the best things as we get older. It's not as high impact. It keeps us strong. It keeps us flexible. So yoga is a wonderful thing to keep involved with as we get older.
So is silver sneakers yoga?
Silver sneakers is your own activity. I mean, you can participate in yoga through silver sneakers at the Y.
I've had a knee replacement, and I don't believe you're supposed to kneel on that. And I found it really hard to get up if you can't kneel.
I can't kneel.
And, I mean, I had a electrolyte imbalance, and I was falling every week, you know. And trying to get up without a kneel is really hard. And do you have any suggestions about that?
I would agree 100%. Getting up without a kneel is just going to take a lot of strength. I mean, scooting, typically what you do is scoot over to a couch and push up with your arms, but you're going to have to be pretty strong.
If
to
you're out
do
by
that.
the car, there's no couch. That's the problem, you know.
True.
Without the tools,
True.
that was happening to me, and thank God that I got that straightened out.
Get that imbalance corrected would be the first step, yes.
And then I haven't had any falls since.
Good.
Yeah.
Good.
I just want to comment about your program. I went through your rehab 23 years ago, but I had a heart valve replaced.
Uh-huh.
And so I was comatose for 6 days after my surgery. And you wouldn't believe the muscle tone that I lost. I remember when I first got on my legs, I had a nurse on either side. They're like, okay, big boy, wait a second. Those legs aren't what you remember. And they were right. It took me a long time. You just wouldn't believe the muscle tone that you lost in those 6 days.
Yeah.
And you got
So,
an excellent program.
well, thank you. 23 years ago is none of us, or we would brag about that.
Yeah, absolutely. I was almost like, yeah, we did great.
But one thing I would say that brings up to light that point, anytime that you stay in bed, so that's what my mom's answer after she fell, is just let me lay down for a few days, I'll be okay. Every day you stay in bed, you lose 3% of your muscle mass, okay? So remember that as you lay there in bed and think it'll get better. Yes, sir, back there.
I live about 9 blocks from the DeSoto facility, and I'd like to know what process you go through for iron therapies. I've been to your facility in DeSoto several times and found that I don't think I got the proper assistance. Then I went to your facility in the hospital. It seemed like it was better. But I would like to know, how do you evaluate new trainees in the therapy coming in to work? Now, the last one I had was in DeSoto, and her name was Hodge, and she quit for more money and went to plumbing. But
You know more about rehab than we do. I said, you know more about our rehab department than we do.
hey, I've been there a lot of times. I'm 53 years old, and I've used your facility several times. But I just like to know, how do we go in and make sure we're gonna get the best therapist that we got?
That's a very good question. That really lies on the people up here. So we do competencies. So we have sheets that they go through for competencies. Jen and our other therapists review their documentation to make sure that they're doing. We watch them do their therapy. So there's personal preference amongst therapists. I have some therapists that do different things in different places, but we hope that that we can keep them competent. But sometimes we don't have the best experiences.
I went to the one in DeSoto several times, and I didn't like the therapist down there at all. And then I went to Festus, to your facility there, and found a couple I really liked and took care of me. And then they insisted I come back down to DeSoto for my back therapy, and Tasha was there, and man, she didn't want it. And, I really didn't get finished with her, but, of course, I know they go where the money is.
Yes, I know that too. All too well. This week, all too well. Any other questions? Yes.
I have 2 artificial knees, and when I called them 3 times this past year, and the only way I can find to get up is to scoot to the basement steps and hold on, and then get up to the front line, stand up on that first step and stand up.
Well, what keep you from falling?
Because I own both sides.
I would say that that would not be the advice method that I would give you. But I would recommend that you have your doctor send you to therapy, because I think maybe we need to get a little stronger to stop the falls. I think that if there's nothing else that you need to take away from this, I think is that we want to stop the falls before they happen. Remaining active and mentally active is the most important part, socially active. So just by doing this is very important to prevent those falls.
She only falls after the 3rd margarita.
Just drink 2.
We get our fair share of those at the hospital also. Anybody else? Okay, I'll give it back to Roger.